Dear Pure Urology viewers, good evening, one and all. Uh, as you all know, female urethroplasty is actually recently coming up. There are a lot of controversies in this. All the urologists know that urethral stenosis is very common. Urethral trauma is not that common, but age-related postmenopausal urethral stenosis is very common, and any injuries related to the obstetric practice are also common. I remember in my training time, Dr. S.K. Singh and Dr. Mayank Agarwal and myself have written large urethrovaginal fistula because of the forceps application, and it was published as a case report. Such things may not be common, but urethral stenosis is very common for ages. Unlike in male urethroplasty, we are still doing dilatation because it is simple procedure and gives results for short period. And most of the patients are happy with that. But slowly, female urethroplasty, anatomical aspects, reconstructive aspects are also evolving like the science in other fields. For the same topic, today's speaker he is Dr. Hemant Kumar Goel. Actually, I came to know him recently for last 1 year about his work in the government institute, and he has taken the department by working hard along with the colleagues, different type of surgeries. Sorry, and different surgeries, and all the surgeries, all the departments related to urology are performed here, and he is giving name to the institute, that is RML Hospital. So to briefly introduce, before I hand over the program, I will share the screen of the today program and introduce Dr. Hemant Goel and then hand over the program. Female urethroplasty is the topic on Pure on 18th. Dr. Hemant Goel, he is the MBBS MS MCH Urology Associate Professor and Head of the Department of Urology and Renal Transplantation, ABVIMS, and Dr. RML Hospital, New Delhi. Performs almost entire urological spectrum with ease, including laparoscopic surgeries, endourological procedures, urethroplasty, pediatric urology, uro-oncology, and all major and minor operations. Special interest in renal transplantation. His special interest is in renal transplantation, endourology, urethroplasty, and pediatric urology. Performed and assisted over 200 renal transplantations. As the course director, Urological Clinics of North India, conducted many workshops. Recently, I came to know that I am also planning to go there for laparoscopic workshop, and Dr. Siddhalinga Swami for our unit has gone for the RIRS, and Dr. Pankaj Wadhwa is my senior who appreciated this workshop very much recently. Actively participates in clinical as well as administrative activities of Dr. RML Hospital and PGIMER and BMMC Safdarjung Hospital, New Delhi. He has more than 30 publications got published in many national and international journals. I wanted to ask you, Hemant, a lot of times I have seen this ABVIMS, RML and Safdarjung as together. Do you give clarification of that? Is it that the government hospitals are all together, or they are combined unit working under some head?
Sir, basically RML Hospital and Safdarjung Hospital, they come under same ministry, the Ministry of Health and Family Welfare.
Okay.
And the functioning is actually combined. Like some of the part is done from RML, some of the part is like they are like sister brother hospital, like from the ministry perspective.
Okay.
So most of the administrative duty either go to RML or Safdarjung, or they are overlapped. So that way we have to take care of, like whatever is done in RML will be replicated in Safdarjung, or Safdarjung whatever they do, it's replicated in RML.
RML Hospital, how big it is? When I was in All India Institute, I remember this hospital very well, but I have not gone recently during MBBS entrance and all this when we are talking about these things. And I heard that the MAMC and RML Hospital are high rated hospitals in Delhi. So how many bedded hospital this is?
It's a 900 bedded hospital. And
My
yeah, and sir, now the seats are the beds are even more increased to by 200 for COVID patients. So now it has become more than 1,000 bedded hospital. And basically, sir, the thing is the RML is actually expanding. Like Safdarjung has expanded with a new super specialty wing. So here also super specialty wing is under construction. So that will be added by in around 2 years. So that will a new feature which is only to super specialty. So
do you have the urology department with MCH here, na?
yes,
MCH
sir.
also.
There are 4 seats per year.
4 seats per year. And uh, separate separate theaters will be available most probably for the urology as well.
Yes, sir. Yes,
Uh,
separate theaters are available for urology.
Radical prostatectomies and partial nephrectomies you are doing regularly.
Regularly, we are doing, sir. So we are
Great.
doing entire spectrum. This reconstructive, actually, Dr. Nikhil sir has special interest. So we have like taken over from him, and we are further developing it. So that way, one thing came from one person, and now we are taking care of everything. Like radical perennial prostatectomy, that came from Dr. Sood. Now we are taking ahead. So
I heard that you do radical perineal prostatectomy also regularly.
yes, sir.
That is your primary choice, or you do both ways.
We do always. We do open retropubic perineal prostatectomy. We do laparoscopic extraperitoneal as well as intraperitoneal. So all four.
For urology, all PCRLs, RIRS, everything is done.
Yes, sir. So
Very
RAS
good.
we were lacking because of armamentarium. So with recent workshop, we are able to get hold of that because in a government setup, that small stones are often ignored. So that's why we did this RAS workshop. Now it's all in place, and we have restarted that program.
Great. So with this introduction, I will request and your interest in female urethroplasty as well as pediatric urology also. Uh, if you don't mind, what are the common pediatric urology surgeries which you do? All cases like hypospadias, the posturethral wall, mega ureter reimplantations, everything will be done.
Yes, sir. Everything we do, majority is hypospadias.
Majority
Majority,
of perspectives.
majority is hypospadias.
Okay. So with this, I will hand over the program. Please proceed, Hemant. Thank you very much for the accepting invitation. Yeah.
Sir, thank you, Chandmohan sir. I think this is second time I am giving lecture on this pure urology forum. This is a very nice forum started by you, the initiative taken by you, and I think I am visible. Sir. I am audible.
Visible, your slides are also clear.
Yes, sir. So, sir, I thank you, the entire team, your entire team, especially to you, sir. And you have started this new way of teaching, learning, and it is very convenient also. It can reach to many people, and some not so hard topics are also we are discussing here. So, without wasting much time, sir, I'll start with my presentation. So,
Yeah.
the scope of presentation is, sir, we'll just have a brief how to diagnose female urethral stricture, how to start treatment, and then I'll share some videos. I have two videos, one on
Yes.
dorsal only urethroplasty and one on ventral only urethroplasty, to give
Okay.
an overview of what was going on and what has changed in the surgical management of female urethral stricture and why it has changed in the surgical management of female urethral stricture. So first of all, I would like to thank Dr. Nikhil Khattar sir. He's a female and reconstructive urologist. He is the one who have taken this reconstructive urology with passion. He contributed greatly to Perineocon 2016 and then to Global Perineocon 2018, which is one of the landmark workshop being done at RML Hospital. At present, he is a visiting faculty in Medanta and Artemis Gurgaon and Holy Family Hospital. He is doing only female and reconstructive urology, and he loves to treat urethral stricture. He is also a lead Hindi vocalist of Strasse. So again, like most urologists, we love our work as well as extracurricular activities. So with female urethra, there are some questions. Is the urethra narrow? When will we say that the urethra is narrow? Is the urethra narrow enough to need a treatment? What is the modality of treatment? Dilatation versus OIU versus reconstruction. Something about urethral anatomy we'll discuss. We'll discuss the approach to surgical treatment of female urethral stricture, dorsal versus ventral, onlay versus inlay, flap versus graft. If we want to use graft, buccal versus vaginal graft, and identifying and treating failures. So about the female urethral caliber, what is the normal female urethral caliber? The problem is with the female urethra is like a female, we are not able to like we don't understand female so much, so the female urethra is same. So there is no normal female urethra. The normal generally is up to like in male everything is defined. In female the literature is very limited. So for normal female urethra calibration around 20 to 23 French is normal, considered to be normal. Now again the narrow urethra definition ranges from less than 10 French to less than 20 French. But most studies, in our study also, we have taken a cutoff of 14 French. If we are not able to calibrate less than 14 French catheter, then we call it a narrow urethra. About the female urethral stricture, around 10% of the female urethra, females with bladder outlet obstruction, they have female urethral stricture. So the important point is the 90% females with symptoms of bladder outlet obstruction will not have female urethral stricture, and they don't need a urethral dilatation or a surgery for female urethral stricture. Any female, elderly female with bladder outlet obstruction is considered to have female urethral stricture, and earlier we used to quote her on a regular or intermittent urethral dilatation, which now is considered wrong. Approximately 40 to 50% of these patients who have female urethral stricture can be treated with urethral dilatation alone. Surgery is an option in female with urethral strictures requiring repeated dilatation. Now, at success, what modalities we have to diagnose the female urethral stricture? So first is symptomatology, a patient with voiding LUTS. Second thing is when a female come with a history of voiding LUTS or obstructed LUTS. The first thing is after ensuring that the urine routine and culture is sterile, we will do a calibration with 14 French catheter. So if it fails, then we have a high suspicion of a urethral stricture and we subject the patient to urethroscopy. Even if there is a success, the 14 French catheter goes. So there is a study, does successful urethral calibration rules out significant female urethral stenosis? The answer is it does not rule out significant urethral stenosis in all the cases. Even after a successful calibration with 14 French catheter, then we have to subject the patient to video urodynamics, or if we don't have video urodynamics, we can do urodynamic study plus MCU. So in that, we rule out other cases of bladder outlet obstruction like primary bladder neck obstruction, dysfunctional voiding, or underactive disclosure. When these are ruled out and patients are suggestive of a high pressure, poor flow, and on MCU it is suggestive of a urethral stricture, then again we subject to urethroscopy. So the point is, even after calibration with 14 French, we can have some flimsy membranous ring with poor rigidity and poor distensibility of the urethra, where the catheter or a cystoscope can be negotiated, but still patient has urethral stricture because the urethra is non-distensible. There is a flimsy membranous ring. So still more than 14 French, a stricture can be there. She may require a surgery for female urethral stricture. The gold standard is a visual demonstration of an anatomical luminal narrowing on urethroscopy. That is the gold standard. So we have to do a good urethroscopy and and when there is a luminal narrowing, a pale looking urethra, a non-distensible urethra, that is a sure sign of a female urethral stricture.
Okay.
About the treatment, we have the first line of treatment when we have diagnosed. So if 100 patients of voiding LUTS female will come to us, only 10 will have female urethral stricture after all this investigation. That is UDS, MCU, and uroflowmetry and a urethral calibration. So we have to judiciously use not all in all the patient, but calibration is used in all the patient, and then as per calibration findings we do further investigation. So once the female urethral stricture is diagnosed, so dilatation, the role of dilatation comes only after the female urethral stricture is diagnosed, not to diagnose the stricture. Okay. So what commonly we do, we dilate any female urethra with lower urinary tract symptoms, and so dilatation is used only after diagnosis, after urethroscopy. So first, that is a very important point. So about the dilatation, there is a pooled study of around 234 cases, and it has a pooled success rate of 49%. So the patient who has not undergone previous urethral dilatation, there is a 75% success rate with only dilatation. And in our practice, on-demand urethral dilatation is superior to intermittent urethral dilatation. Multiple urethral dilatation may further damage the urethra and compromise the outcome of future reconstructive surgeries. So for me, a male stricture and a female stricture will not differ. In a male, I'll do a single time OIU, maximum I'll do a 2 times I'll do OIU, and if it recurs, I'll do a urethroplasty. In female also, I'll do single time dilatation. Maybe if she's asymptomatic for 1 year or 1.5 years, I may do a second time dilatation. But if it recurs, then I'll subject it to urethroplasty. So for me or in an institute, we don't differ the management of male urethral stricture and female urethral stricture. The
Okay.
result has been that like 6 years back, there are a lot of female which were on urethral dilatation. At present, there are only 2 or 3 patients who are on urethral dilatation. Rest, either they have been treated with single urethral dilatation or they have been subjected to female urethral stricture. So the important thing is the what we fear about a surgery or in a female urethral stricture is incontinence. So continence in women is actually multifactorial. There is a permanent urethral closure forces in the form of resting tone and sphincters. There is adjunctive closure forces in the form of cuff, pelvic floor, and there is sealing effect in the form of submucosal vascular plexus, which is hormonal and age dependent. The important about this slide is there is no single factor which contribute to continence in female. So with the surgery, this is the last thing which we see is the female incontinence after dorsal only or ventral only reconstructive procedures. So because it is multifactorial in female, there is no single factor. In male, if we do a poor TURP or a HOLEP, the patient may be incontinent if we have damaged the sphincter. But in female, it is multifactorial. So incontinence after surgery is very rare. This is a diagram of female urethra. Again, it is very difficult to understand. It is multifactorial. And like male, there is a simple sphincter. It's not the same condition in female. The important thing is in female, there is no corpus spongiosum around the female urethra. Also, one important concept to understand is what we think for a dorsal only procedure, the clitoral body will form the bed for dorsal graft, but that is not the condition. It is not the clitoral body, and clitoral nerves do not get damaged in dorsal dissection. This
Okay.
is important. Now, for the reconstruction, after we have done urethral dilatation and a patient has recurrent, the till now importance is to diagnose female urethral stricture. Then we do urethral dilatation, single attempt. And we see the importance is the patient should improve after urethral dilatation, and that should be there for some time. So the patient has improved, so that confirms our diagnosis. If the patient in 74% of the cases, the patient will not require further urethral dilatation. If she is requiring further recurrent urethral dilatation, we subject that patient to surgical procedure. So the surgical procedure what we have is a dorsal only procedure, ventral only procedure. We have inlay in the form of dorsal or inlay. Then generally we use graft. We prefer buccal mucosal graft. We can also use vaginal mucosal graft, and we can use local tissue flaps in case of recurrent or surgical failures. So I'll start with dorsal onlay graft urethroplasty. So this was one paper which was published from our institute, where we have seen the effect of this surgery on female urethral sexual function. And actually, we have seen the dorsal onlay graft urethroplasty improve sexual function. Initially, there was a concern that with dorsal dissection, the clitoral nerves will be damaged and the patient will have poor sexual function. But actually, after the surgical management, the sexual function improves. So this is again one diagram of ventral only graft urethroplasty. The entire video I'll show. This chapter we published in bladder outlet obstruction and urethral reconstruction. This was the main editor. Main editor was Dr. Nikhil Khattar, Dr. Arvind Panda, and Dr. Rishi Nair sir. And this was one of the chapter which was written by our department.
Great.
Between the dorsal versus ventral approach, the importance of the dorsal approach is it avoids fistula, any urethrovaginal fistula it avoids. It preserves the plane for further incontinence surgery, which we generally do from the ventral aspect. It provides good graft bed. It interferes with sexuality. De novo incontinence is there. It is more vascular. The dorsal approach is more vascular. There is more bleeding. It is less familiar to urologists. Now the ventral approach, there is minimum urethral mobilization. That is the maximum advantage is because there is minimum urethral mobilization. There is less pain, less blood loss. It preserves sexuality. There is no nerves which are coming there. Less chance of de novo stress incontinence, and it is more familiar to urologists because we normally do VVF and UVF. So that is a plane which we are more familiar. Now I have two videos. One video is of dorsal only graft urethroplasty and one of ventral only. Dorsal only again I have taken from Dr. Nikhil Khattar sir. This was the MC of the patient, which is showing a mid-urethral stricture. So the my technique and Dr. Nikhil sir technique is a bit different. I'll just start with a dorsal only approach. So he will do the urethroskopy first. He'll confirm the stricture. Then he dilates a bit and he put a 12 French catheter in the urethra. and start with the two-stage suture we have taken at 3 o'clock and 9 o'clock, and a dorsal dissection is done. From 3 o'clock to 9 o'clock, the entire urethra is mobilized dorsally. This dissection should be done carefully. Basically, we should not make the urethra very thin. When we do this dissection, there is a clear plane.
Yeah.
So the disadvantage, like I do generally a ventral approach. So I'll just start with the advantage and disadvantages. So here we are making the dorsal mobilization of the urethra, and we go all along till bladder neck. Once we have done sufficient mobilization, we open the stricture from meatus till the, so we calibrate with 30 French dilator. We open the stricture till we encounter healthy mucosa, like in male stricture.
Yeah. Lot of people will ask, if the stricture is proximal, should we go up to the bladder neck like that? Is it possible to go up to the bladder neck in this method?
But the problem, that is the main problem with dorsal approach. So it is possible to go till bladder neck. Definitely it is possible to go till bladder neck. But the problem is in dorsal, for what I feel, in dorsal approach, the bladder, from the bladder neck goes anteriorly.
Yeah.
So that anterior part we cannot cut.
Yes.
The ventral approach, from the posterior, it will go just flat, straight.
Yes.
So that part, it's easy to deal ventrally. So sir, I actually did initial, what we did is I always used to do this dorsal approach. The problem was with the bladder neck only. If the structure was too proximal. So
Sir,
first thing is the opening of the bladder neck was difficult. Second is to take sutures that deep is again difficult. And the recurrence, if we don't cut the structure fully, then the recurrence will be high. So in this approach, we have mobilized the urethra dorsally. Then we have opened the stricture almost till the bladder neck. We have taken the graft. In this, the important is we can take from the lips also. We can take from the tongue, on we can take from the buccal mucosa. Whatever graft we take, we should thin it. It should not be very thick graft, because this is used in female urethra. So it should be very thin graft. So we should remove all the fat over the graft and make it thin.
yes.
So again, we start from the apex. Now there are two ways to fix this graft to the urethral edges. One is the urethra on the patch or patch on the urethra. Like initially, what we were doing is we were like in male urethroplasty, we were attaching this patch on the urethra, like normally what people do. So then we saw that there are some failures. So what we have modified is now we quilt this graft to the dorsal bed.
As and when the bites are taken.
Yes, sir. So now we are not, we have taken the apex sutures, and then we are fixing this graft, buccal mucosa, to the roof.
Okay, first we will fix it.
Yeah, we fix it to the roof. So this is urethra on patch.
Okay.
So patch we have fixed. Now urethra ke both the margins will take, and we'll suture it to the margin of the urethra.
Free edges of the graft.
Yeah. So in a way, we have quilled this urethra, this graft.
Okay.
So this is something which is new, patch on urethra and urethra on the patch. So initially, what we were doing urethra on the patch, conventional dorsal only. We'll take it from the apex and we'll suture it to both the margin of the urethra. Now we have just modified it to patch on urethra. This urethral graft, we'll fix it on the roof, and then we'll suture it with both the edges of urethra. I think you got it, sir?
Yes. So first you fix on the bed, that is called patch.
Yes.
And then suture the fixed buccal mucosa to the edges of the urethra on either side.
Yes. So we have done a form of quilting first, like we do in dorsal only in males.
Yeah.
We take apex sutures and then we take quilting sutures.
Yes.
To the bed, and then we suture it to both the margins of the urethra.
Yes.
Same thing we are doing in female urethroplasty also.
Okay.
So the thing is, sir, we just after doing all the permutation combination, we are replicating actually what we do in female male urethroplasties.
Yes, yes.
So in the, otherwise, after we have sutured, then to do quilting is very difficult because there is very limited space. So now we have done the quilting part first, and then we are suturing it.
Edge.
So this is the technique part is not very difficult. The problem
Yes.
with dorsal only what I have felt is that one thing is we to go beyond the bladder neck is difficult. Second thing is we were compromising the meatus in all the cases. We have to open meatus in all the cases because not in all the cases of urethral stricture meatus is involved. Most of the cases it is mid urethral stricture.
Okay.
And it is the meatus and the distal 1 centimeter of the urethra is normal. So, like again in male, if the meatus is not involved, we will avoid opening the meatus. So again, in dorsal approach, it was difficult. Although we have tried meatus preserving dorsal only urethroplasty also, but it was difficult.
Difficult.
So those two limitation which were there to me was one was meatus was compromised in all the cases, and second thing is that the proximal dissection till the bladder neck is difficult. Sometimes the stricture was very proximal, so in that cases there were some failures.
Yeah.
So with that, I think this video is over.
Yes.
So, sir, this is one of the photograph where we have tried a meatus preserving dorsal only also. The procedure was same. Only thing is we tried we preserved the meatus part. So we have mobilized the urethra but preserved the meatus part, and then we have done a only procedure, dorsal only.
Very small.
Yeah, small.
Like.
But still, sir, if the meatus is preserved, the splaying of the urine post-operative is minimized.
Yes, yes.
So once we open the meatus, then it becomes very wide open.
Wide open.
With 1/3 covered by the buccal mucosa.
Like too much myotoplasty in males can lead to.
So that's the meatus has a definite function. Even if we can preserve this much meatus,
Yes.
that will help in post-operative results. The splaying part will be less.
Yeah.
So, sir, with this, we have started now ventral augmented urethroplasty. Actually, this started with a thesis. We have compared ventral only with dorsal only, and that time we were searching. Nobody actually in India was doing a ventral only procedure because there was a fear of a urethrovaginal fistula. That was the biggest fear.
Yes,
But
yes.
we searched for the literature. The urethrovaginal fistula rate were very minimal, very minimal. So we started with this. Initially, we were doing a procedure similar to a dorsal only. We opened the meatus till the stricture, and then we did a almost similar type of procedure in a ventral only. Then we modified it to a meatus preserving ventral only urethroplasty, which can be very easily done from the ventral side. So I'll be demonstrating one video of ventral meatus preserving ventral only urethroplasty. This was a 35-year-old female. She had a history of multiple dilatation followed by temporary relief. Evaluation was normal. Uroflowmetry was suggestive of an obstructed pattern. MCU is suggestive of a mid-urethral stricture. UDS was suggestive of high pressure, low flow. So it was suggestive of a stricture. So this was one of my video. In this, sir, my step is a bit different because I don't dilate the urethra on table. I'll just do a urethoscopy and initially I put a guide wire.
Okay.
Because after, I feel once I dilate the urethra, then stricturotomy becomes it's like again like a male stricture. If I do OIU and then I do a urethroplasty, it will be difficult.
Yes, yes.
So I just want a catheter or a guide wire inside. A
In this context, methylene blue not much useful, I think, in female.
not in female, so we have not tried in female.
Yeah.
So the first step is a urethroskopy with a uretroscope, 6 French uretroscope, and a guide wire placement.
Yes.
It's not playing.
It's playing. Go to previous slide and then come back.
It's playing. Take it.
Or else fast forward a little bit. Yes. Leave it.
One more eye.
Go to.
I think I'll directly play the video.
Yeah, go to the video and play. No problem.
I'll just stop this.
Yeah, yeah.
Sorry. Visible now, sir?
Yes, yes.
Yeah. So, sir, the first step is the urethroscopy. We do with a 6 French uretroscope. We just
Yes.
visualize the stricture. It is dense, and then we place a guide wire and a 6 French ureteric catheter over it. So, sir, sometimes what happens even after all this investigation, when we scope the patient, it's a very flimsy stricture. So that time we just do a dilatation, but otherwise the second step is after we have done this ureteric catheter, we do anterior vaginal wall flap creation. So here we take a inverted U shape from meatus, like we do in vesicovaginal fistula. Only thing it is from meatus till downwards, inverted U shape.
Yes. Tongue type.
Yes. And this meatus preserving, we do only in that case in which at least distal 1 centimeter of urethra is normal.
Normal.
This is the first layer. Here we've taken. The second is the paraurethral flap tissue. So the urethra is actually, there is a urethra, there is a paraurethral tissue, and then there is a vaginal flap. So once we have taken the vaginal flap, paraurethral flap creation is not always possible because there is a stricture. So sometimes this paraurethral tissue is adhered to that stricture. So second thing is after we have raised the this flap, we just calibrate the urethra. So around a half centimeter, 1 centimeter of 18 French Foley is going. Then we do a stricturotomy. The important is we don't have to mobilize the urethra in this. We are doing a stricturotomy, ventral. This meatus we have preserved.
Yeah.
We just taken a stay suture on the distal aspect of the stricture. All three sutures have been taken. This is the open urethra. Now the important is we can preserve the meatus. Second thing is the suturing is very easy in this because it's directly in front of you. The bleeding is minimal. Then we take the graft again. For the graft initially, sir, we were taking vaginal mucosal flap, but the recurrence was more, so we have now shifted to buccal mucosa. We only use buccal or lip or tongue. We don't use vaginal mucosa anymore because it is hormonal dependent and postmenopausal it is not very healthy.
Okay.
Again, it's the suturing part is very easy. We take apex sutures. Both the medial and lateral part of the graft is sutured to both medial and lateral wall of open urethra.
You are suturing the edges first, unlike in dorsal.
Yes, sir. Because here, sir, there is actually the bed will be of paraurethral tissue, which is the second layer.
Yes, yes.
So we'll do, sir. Basically, the dorsal only is done like dorsal only in male, and
Yeah.
ventral only is done like ventral only in male.
Yes, yes.
So in that also in ventral only in male also we first suture it and then we quilt it when we take the second layer
Yes,
of
yes.
paraurethral tissue.
It's
So
like
that
closure over that.
yes, sir. So we'll do that in this also. First we have done completed the first layer.
Yeah.
So after you have completed the first layer, you can see the second layer of paraurethral tissue very clearly in this.
Yes.
see the para-urethral tissue here. So it will be. I think you can
Oh,
here
yeah.
you can see this is the para-urethral tissue layer. You
Okay.
can see the graft here,
Yes, yes.
and this is the para-urethral tissue. So second layer, when we take the para-urethral tissue, we'll quilt it simultaneously, like in ventral only in males.
Yeah.
Take a both ends and
It's more or less a covering, but you will take a quilt.
quilt it. Yes, sir. We take from here, we take a part of mucosa and then the opposite side of the parietal tissue. So I feel that for the prevention of this urethrovaginal fistula, a good closure of this parietal tissue is very important because all the vascularity is provided by this parietal tissue.
Yeah.
After this, we do our anterior vaginal wall reconstruction. So as you can sir, appreciate, the meatus is absolutely normal in this. We have
Yeah.
not done anything to the meatus. We do a vaginal packing. We remove the packing on day 2 and we remove the catheter on day 14. And in same thing in dorsal only also the follow up is entirely same. I'll just share my PPT again.
Yes, yes.
Sir, we have done this study of ventral versus dorsal only. It was a prospective randomized single institutional study, and it was done in year 2018, 2019, pre-pandemic. 12 patients we have operated in each group, and we have evaluated on subjective and objective outcome measures. So what we have found is that in a dorsal approach, it is a more vascular bed for graft. Meatus preservation is difficult due to limited space. Proximal dissection around neck is difficult in a dorsal approach. There is dissection around sphincter and can possibly disrupt nerve and vascular supply to the clitoris as well as clitoral bulbar tissue, potentially causing intraoperative bleeding and potential postoperative sexual dysfunction. But this sexual dysfunction has not been proved. In studies, it has shown that with a female urethroplasty, the studies about ventral approach are less, but with dorsal approach, the sexual function improves. There is no study about ventral approach. Ventral approach, it is easier dissection of proximal urethra near the bladder neck. We can go as high as possible. There is no difficulty in going proximal to bladder neck also, although we avoid bladder neck and proximal to that. Easier meatus preservation is there as compared to dorsal. There is lesser bleeding, more familiar dissection for urologists. There is a theoretical chance of UVF. But sir, I have done almost 15 cases. There is no urethrovaginal fistula, zero. And in literature also, there is no substantial urethrovaginal fistula after ventral approach. The inlay approaches have also been described. Personally, I really don't prefer inlay approach because in that again we have to wide open. We have to open the urethral stricture, and then we have to do suturing from inside, which is technically very difficult, and it is not applicable to all the strictures. It is applicable to strictures which are present at the level of urethral meatus and distal urethral stricture. So I have personally tried in 1 or 2 cases, but I generally do ventral approach only now.
Yeah.
So then if we see about the literature, in a pooled success rate of dorsal approach is 88%, of ventral approach is 95%. And also about the graft, the BMG urethroplasty has a bit higher success rate of 89% as compared to 87% of vaginal graft urethroplasty. So dorsal approach is used in majority of the cases because it has become popular earlier, and it is in pooled analysis, it was used in 140 out of 211 patients. Dorsal approach was used. Pooled success rate of ventral is slightly better than dorsal. De novo incontinence is also less in ventral as compared to dorsal. Sexual function does not deteriorate, rather improves after dorsal. It also improves after ventral, but the data is not there.
Yeah.
What do we call success after female urethroplasty? So like in male, there should be no need for instrumentation, flow rate of more than 50 ml per second, and there should be improvement in quality of life. One more thing is the natural state of a female urethra is to show thrown in folds. So there are more chances of formation of synechia or cos adhesions. What we have seen, like after a female urethroplasty, the patient present with persistent LUTS. Because the female urethra is collapsed in a natural state, it is collapsed. So there is some synechial formation, the early synechial formation. So when the patient has persistent lower urinary tract symptoms even after surgery, then we recommend that urethroscopy should be performed early to break the synechiae, and so that the patient get benefit of the surgery. So the synechial formation is there. So immediately,
Catheter how many days you keep so that Sinike is chances will be less? 2 weeks?
so 2 weeks we keep, 2 weeks we keep, 2 to 3 weeks. In some cases,
Or
we
we even then we can get Sinike?
yes, sir. So around 10 to 20% of the patient will have some symptoms even after this surgery. So
Yes.
it's not like male. It's the patient will have some borderline flows. The like it's the results actually have not been like male urethroplasty. Once you do male urethroplasty, the patient has excellent flow. So here around 70% patient will have a good flow. They will not require any instrumentation. But 10% there can be failure also. There was a 10% failure in our series also, and 20% patient will have some sort of synechial formation or some problem. We will require one cystoscopy. So
Yes.
that is there.
Okay.
The flaps, sir, we generally use in redo cases when there is failure even after female urethroplasty. And sir, I think that's all about the female urethral stricture. With this, sir, I also invite the entire people to our Global Perinicon 3.0. This is one of the landmark workshop where we do all type of perineal surgeries: perineal prostatectomy, female urethroplasty, male urethroplasty, VVFs, urethrovaginal fistula. Very difficult surgeries. To show 20 of such cases in 2 days is very difficult. So we are doing it after a gap of 5 years. So it will be in April 2023. So just
What are all the different surgeries generally you last conferences you have done?
sir, in this Perinicon.
No.
Then in Perinicon, we do one entire day we do male surgeries, and one entire day we do female surgeries. In female, we do mainly genitourinary fistulas,
Okay.
all sort of VVF, redo VVF, radiation-induced VVF, urethrovaginal fistula, incontinence surgeries, TOT, TBT, pivovaginal slings. And
Okay.
if you found any other good surgeries, cystocele also. And male, sir, we do perineal prostatectomy, we do AUS, we do penile implant, difficult rectourethral fistulas, difficult urethral reconstructive surgeries like difficult PFUD with rectourethral fistula. So it's like a complicated, complex reconstructive procedures we demonstrate.
Great. So every year you do in April month.
Sir, no, sir, we have done in April. Yes, sir, we tried to do it in April. We have done in April 2016. In 2016, we have done. Then we have done in 2018. We planned in 2020, but because of
Correct.
COVID, we have to postpone. So we have planned in April 2023. Actually, sir, for this we need a preparation of at least 6 to 9 months, because these to find these patient is not
Difficult,
easy.
difficult. And what is your? We will just close this. What is your current, uh, your experience and current your recommendation for the vesicovaginal fistula repair? Recently, I have shared a video in a 150 kg obese patient, high BMI, intratrigonal fistula. After that, I thought that it might have been easy for pervasion. My God, it was very difficult by evolving from entire length to length, and the so intestine was adherent to one small perforation, then suture, then go taking deep bites in lap was really nightmare. So, do you think a VVF can be approached easily through vagina up to what level? Any small, even though it is not related to urethroplasty, because you are doing a lot of perineal surgery. What is your comment on it?
Sir, personally, sir, in our institute, we do all cases of VVF vaginally. Even if they are supratrigonal, intertrigonal, any case, a large VVF also, we do vaginal route. Sir, abdominal we do only if we want to do a lab VVF. That is one indication if some faculty want to do a lab VVF. Second thing is, sir, if the ureters are involved, if we have to do a ureteric implantation. Even if it is very close to ureteric orifice, then also we do vaginally, because we can easily spare ureteric orifice from the vaginal route. So, sir,
That means
90
you
what?
dissect, you incise a circumferential incision around the fistula and dissect between the vagina and bladder directly
Yes, sir. Yes.
with place stitches pulling and just scissors and blunt dissection directly you will dissect between the two planes.
Yes, sir. So we make a good flap. Basically, sir, we in vaginal route we don't have to. We just have to push bladder away. It's all the vaginal flap which does the work. And so the so even if the ureteric orifice is very close to fistula margin, then
It is
also we can preserve that. Yes, sir.
no any interposition of the tissue is not required.
In majority of the cases, but in recurrent VVF, large VVF, we do Marshall's flap. And sir, in like post-hysterectomy fistula, we do peritoneal or omental flap because it's very easy to pull peritoneum or omentum from upside up. If it's a post-hysterectomy fistula, because
Oh.
the uterus is not there, so generally the peritoneum and omentum is stuck to that place.
Jackknife position standard.
Sir, we do in standard position. I think Dr. Gopal Krishnan, sir, he is doing, or Dr. Dalila, he is doing in jackknife position. We are comfortable in a standard lithotomy position. So I do in,
Economy position.
yes, sir, standard.
You'll use the headlights and for
Sir,
any
Dr.
magnification and headlights are not that much necessary.
Sir, again, sir, Dr. Nikhil is using headlights. I am not using headlights on anything. I just focus light on my shoulder, and I am able to visualize and able to demonstrate also.
Deep,
So,
deep region you will pull through the stay stitches normally.
sir, in a post-hysterectomy fistula, when it is at dome, in that case, we calibrate the fistula with a catheter and we pull it into our field.
Yeah.
So it's specifically in post-hysterectomy fistula where we're doing a let's go repair. Again, in a normal anterior vaginal wall fistula, it's okay. We can just reach till that place. So that's the beauty of vaginal VVF. The post-operative recovery is excellent. The results are very good. Basically we can do in any habitus of patient. Like it's a very morbidly obese any patient. The vaginal part
That
or
means
perineal part is okay.
sometimes you fast a Foley's catheter, inflate the balloon and pull it and then dissect slowly and then take out the Foley's and then suture like that.
Yes, sir. For
Through the
doing
fistula, you will pass a Foley's catheter.
what, sir?
Through the fistula, you will pass a small Foley's and then pull it.
Yes, sir. If the fistula, if the Foley's is not going, then we dilate the fistula over a guide wire and then put a Foley's. So it's a high fistula, we always put Foley's. Our 8 French Foley's is always there.
So that will help to drag the tissue down and suture.
Yes, attraction is easy and the creation of flaps is also easy because there is attraction. So that pulls the vaginal epithelium also, the creation of flaps will be easy.
If you want to do any flaps, will you call plastic surgeon or you only will do Marshall's flap, any other flaps local?
We do all the flaps, sir. Marshall's flap, Greshali's flap. We
नहीं,
do.
आप लोग ही करते, you only do it.
Yes, sir. We only in Greshali's flap, we mark the perforators by plastic surgeons. So they mark the perforators. Rest on table we do. So it's one day before we just send them to mark the perforators because they have their ultrasound machine. So they just mark the perforators.
Okay. And any complex recurrent post radiotherapy fistula also you do like that?
Yes. Only thing is, sir, if it is a very large, then we prefer it to do it from the abdominal route. So if it's very like radiation fistula, we take care whatever the best route that we'll try to do. Sometimes the patient has small bladder capacity also, along with this radiation fistula. So we will have
Very
to do.
difficult, I think. Radiation fistula are very difficult.
So we have done along with bladder augmentation. So in that case, we have to see the bladder capacity and we have to augment the bladder along with fistula repair. That can be done abdominally only. So if we in a small bladder capacity we do a fistula repair, it will recur. So we have to augment it.
So coming to the female urethroplasty, we have started recently by Dr. Soundarya, who is a female urologist in our center, and she has done around 25 cases, out of which 3 have failed and 21 are doing well. Reason we don't know. Within 1 year they have stenosed and we kept on dilatation program. Just out of curiosity, if we have failed dorsal, we are doing only dorsal. Now I have seen your ventral. If you take a U flap, there is a lot of thick tissue. Chances of fistula are very unlikely unless it is infected. That also nice cover will be there. If dorsal fails, can we try ventral buccal mucosal graft? I think without any problem. I think.
We have actually done dorsal fail. We have done again a re-dorsal urethroplasty also. So that is also easy. But somehow changing the route is, I don't feel it is a good idea because we have, then the chances of incontinence will be more according to me because we have damaged the structure on the dorsal side, then we damage the structure on the ventral side. So that is apprehension. So
Okay.
I have changed the route in female urethra.
That's
If
a valid point because That's not good. Incontinence is a
Yeah,
it's not good.
difficult thing in female. So generally, with the dilatation or cystoscopy, these stricture don't recur after.
We comment on post radiation therapy stricture. They are very common. They bleed the moment you touch the urethra, the moment you touch the vagina. Annoying problem is post radiotherapy for the squamous cell carcinoma of the cervix, and they present with urethral stenosis and small bladder, all inflamed edematous bladder. What do you do these patients?
Sir, practically, sir, we have seen fistula, post-radiotherapy fistula we have seen, but post-radiotherapy urethral stenosis, well, I have not operated on such patient. Maybe that if we have done urethral dilatation or I think some patient like these sort of patient, I think we should not operate. The main thing is that unhealthy tissues we should not operate because the chances of complication will more. So it's better to do safe, that is urethral dilatation in these patients.
Normally, in female urethra, when they come to dilatation, do you believe in too much 30 French dilatation for 15 minutes, leave it and then do, or 24 dilatation optimum time and 5 minutes and then leave it?
Personally,
Over
sir,
dilatation, what I mean to ask, over dilatation, does it work for more period of time?
what I do is I do dilatation till there is some blood. When there is first evidence of a blood, that means it has traumatized the mucosa. That time I stop. So maybe it is 18 French, 20 French, 22 French, 24 French. But whenever there is a blood at meatus, that means I'll stop.
As long as urethra can accommodate the elasticity slowly, you do it once it cannot and break, it you stop it there
Okay.
because it causes fibrosis.
Yes. Otherwise, if I want to overdilate, I'll do a OIU or OT.
One question was asked by Sandeep, role of Otis urethrotomy and self-dilatation in female patients.
So, sir, the answer I've already answered that if there is a very dense stricture, I cannot do urethroplasty. I won't do a urethral dilatation, forceful urethral dilatation. Better is I do a controlled OIU or OTIS. In female, OIU we do in the form of OTIS. So that we do when we cannot do surgery. Like say there was some patient of recurrent urethral stricture. Even after 2 attempts, there was a recurrent urethral stricture. In that patient, we have done OTIS. So dilatation is only reserved for first or second time.
Yeah,
If there is a recurrent stricture or there is a very dense stricture where we cannot do urethroplasty, we'll do a OTIS.
yeah. And Otis and dilatations are all done under local anesthesia, no? Mostly.
Yes, sir. Ideally OTIS should be done under regional, but we do under local anesthesia only. Dilatation is definitely done under local.
Procedure under spinal, buccal mucous erythroplasty under
Yes,
spinal, or
very easily can be done under spinal because we take a very small 2 centimeter under local anesthesia from the oral mucosa.
or
It is can be done. It is a half an hour procedure, not a very like lengthy procedure.
last couple of questions. With your experience in male and female erythroplasty, especially male, do you have any personal preference over lingual versus buccal? Buccal, of course, easy. I am asking you theoretical question. Have you used lingual grafts regularly?
So, sir, we have generally we use buccal. The
Yeah.
reason is the residents are trained in taking buccal, and I am generally doing a urethroplasty part. But lingual also we have taken when the patient has a lot of BXO changes. So we have actually taken a lot of graft. We have taken buccal, we have taken lingual. We have done saphenous. We have done around 40 cases of saphenous vein graft
How is it
urethroplasty.
result? How is it in male? Saphenous result?
The results are very good.
Very
And
good.
yeah, the best part is the length. There is no limitation of length, and the vein graft is a substitute of urethra. It is like urethra only. So the results are very good. Only thing initially it
And
was
inflammation and quilting comes nicely, or
very nice, very nice.
is
The
it
only thing is we have to preoperatively we have to do ultrasound again to see the lumen of the saphenous vein. It should not be very narrow.
damaged one? Should not
Initially,
be damaged one.
yes, sir. It should not be narrow and it should not be damaged. Second thing is deep veins. We have to see that they are patent. Third is initially we were taking a long incision along the saphenous vein to extract the entire saphenous vein. Now we are doing it by a small 1 centimeter 3 incision. We are extracting the entire saphenous vein. So
So,
that
lengthwise, you cut open like a tube and then put it on the bed, reversed one at the bed.
Yes, so we do actually hydrodistension. We block one end of your vein. We push saline from other side, so it hydrodistance, and then
Okay.
we cut the so that the lumen will increase a bit. And sir, about the lingual, the it is also very nice. It's very thin graft, and the results are equally good. So, but somehow we have used it less often. Either we were using buccal, or then we started using saphenous. So where the buccal was not suitable, we used to take saphenous.
Okay. And last question in flaps also in urethroplasty. I mean, I am asking because female urethroplasty is not that big subject. I'm just combining for the audience, juniors maybe, because you are doing in government institutions only. These urethroplasties complex cases will come. That's why I'm asking this question. Flaps in failed buccal mucosa. Do you in adults have you done this QWERTY or other flaps? Any experience, or you are not doing regularly?
We are doing not very regularly, but whenever they are required,
Doing.
that time we are doing. And like Macanich flap, we generally reserve for recurrent fistulas only. So Macanich we have done not quadri flap I have not done, but Macanich we have done. And so, but the thing is, the results are not very good. Like
Yeah.
in our experience, the
These surgeons across the world are not favoring the flaps.
yes.
There's a lot last resort for them.
Yes, so we have also done, sir, but I am not satisfied with the these flap procedure in like reconstructive male reconstructive surgeries. The results are not very good. Better I'll do a stage procedure and I'll do a second stage proper.
You can
So
say Johansson's.
yeah,
Yes. Sure. Good. Very nice discussion. Thank you very much. We spent hour without knowing that, and you have shown both the videos very well. It is giving for us also interest because recently we are doing more than two dilatations. We are not doing. We are converting into buccal mucourethroplasty. Now it is time we have to look for the ventral, as you shown the tongue flap or U flap, and then properly covering it back is useful. And second point, very interesting is meatus. If it is normal, why unnecessarily cut it? Go back a little bit 2 centimeters, and then natural meatus is natural meatus for the normal flow without any splaying on the backside. That is good. These 2 points are very good. If you focus and do keep doing, these points will be and highlight, and the juniors can learn from you. That's very useful. Thank you very much for the presentation.
thank you.
Thank you. Thank you very much. With this, we